So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
Jimmy Pruitt, aka PharmD and ED, and I'm bringing you another episode of the Pharm So Hard Podcast. Today we have a special episode. As you can see, we're recording somewhere a little different, doing something a little different, and this is going to be a fun time for us in this episode. We're going to be having a debate. We're going to be going back and forth with the things that every ED talks about. Is going to be talking about RSI, particularly with the paralytics. But before we get into this, if they haven't heard you on our previous episode together, can you please introduce yourself for the audience and let them know where you're at?
Yeah, my name's Rosa Post. I'm now PGY3 at Carolinas Medical Center, resident in the emergency department. This is the second time that I've been on this podcast. I love it. I love all things EM and critical care pharm. I like tox. I like critical care. And I like airway stuff. So this is right up my alley. So
it's a combination because it's like you're going to be just combining all the medications, and we're going to be talking about really just two in particular. We can pretend that Vex in the conversation in today's world, but it's not. We can pretend that some of the other things, Succinylcholine has never been in the conversation. We got two big things: Rocuronium versus Succs. But before we get into too deep with all of that, I want to kind of talk about what RSI is, because we haven't actually done an episode on RSI to really kind of talk through the logistics of what you're going to be doing, the things we're going to be preparing, the drugs we're going to be asking about. So before we jump into that, again, RSI in itself is going to be super important to be able to quickly establish an airway for a patient. There can be a host of different reasons we do so. But can you talk to us about like the role of RSI in helping you basically get the tube and ensuring the patient is fine?
Yeah. So, I mean, I think for, non-optimized emergent intubations, the trend or the standard really is for rapid sequence intubation, which is a induction sedative agent followed very, very closely by a paralytic that induces quick sedation and then paralysis. That's ideal for then very quickly getting the tube in. So that's what RSI is. And there's, for us in the emergency department, that's the standard for the most part. Yeah. There's of course, there's other modalities of, fixing an airway and getting a definitive airway. But for the vast majority of what we do, it's RSI.
Yeah. And I think RSI, like every specialty has their like thing. And I think for the ED, I think most people can say like RSI is like our thing. Like unstable patients or patients that we just don't know much about, and being able to quickly establish an airway, that's like the thing that we do. And no matter where you go, and I've been a few different places, the way we look at this is like figuring out which agent we're going to use. And some I'm kind of like one versus the other. Let's fix it. You can use whatever agent you want. But some people get very emotional about this, and they will fight you, especially ED versus like pharmacologic versus anesthesia. It can become a kind of a very intriguing battle.
Yeah. It's like people like have feelings about it. Like it's like a human, but it's these are just drugs, people. But everyone comes with different experiences, and, one agent has, a pretty long history, and people who have trained in the past or even the recent past, are pretty much only trained with succinylcholine. And I'm sort of this, as a infant to teenage doctor, kind of growing up in a place where rocuronium is really the majority of the paralytic that I use.
Yeah. So I think it's intriguing because like when we look at the different agents, so succinylcholine is going to be our depolarizing agent. And it's cool because we have the fasciculations that happen due to depolarization. And I think most people just like to say the patient is fasciculating. They like the way it rolls off their lips. But just seeing those contractions go upwards into the last thing being a diaphragm to facilitate that. And I like to tell people all the time, it's like the paralytic for the provider, the inductions for the patient. So we can argue about whatever, knock the patient out. I don't care how you do it, long as the patient's out. But then this whole concept of which paralytic to use, and we'll get into the data, is going to be based off of how can we establish this tube right the first time. Mm-hmm. So onset of succinylcholine is going to be about 40 to 60 seconds. I usually see a little sooner than that, but that's the textbook duration, anywhere from 4 to 10 minutes. The fact that it's going to be rapidly hydrolyzed by plasma pseudoesterases, only about 10% of it's going to be renally The things you have to worry about is potential for bradycardia, hyperkalemia, those recirculations, increased intraocular pressure, a transient, very small increase in intracranial pressure. That's another debate that's really been debunked since the 90s, that people like to talk about it still.
Yeah.
But again, it's not really a huge of a thing. We're talking about anywhere from like 5 to 10 increase in that, and it kind of goes down right after. And then the rare, very serious thing that I've seen happen once is malignant hypothermia, which is horrible and tough. Another cool thing about Succs that I bring up is that this whole component of phase 2 block, phase 2 being you give a dose, you get in trouble, and then you have to give another dose.
Mm-hmm.
Back in the 80s, we used to give infusions of succinylcholine, which is intriguing, but we do Nimbex, we do a few different things.
Yeah, we do Nimbex.
But like high dose that, we found that after you give that first dose, the body's gonna be sensitized to it, and you can have like pretty profound bradycardia, and then you can have a prolonged duration. Much longer than what we traditionally see, but that usually only happens with the second dose. You can also see bradycardia more common in kids. And I want to preference this talk for all my pediatric people. This is mostly about adult. This is what we practice in, and most of us do that. Whatever you want to use for your patients, please do. I will not be an expert in that. So Kelsey and Emily, don't kill me. Okay. Yeah. This is solely for adults. Then we got Rock, our non-depolarizing muscular rocker. And I think it's funny when I have interns come in, it's like, oh, he's vasculating. I was like,
nah, fam.
He's not.
Yeah. Or the classic intern trauma secondary survey of rectal tone. And after getting rocked 20 minutes beforehand, it's like, nah,
you don't got nothing, fam.
You ain't got nothing, fam.
So onset, for the doses that we use, and we'll get into a little bit of the doses that we use. Again, we're talking this 1 to 1.2, and sometimes people are talking about going up to 1.5 mg per kg. And then there's a conversation of that's the dosing, but then based on what weight? Is it regular weight, lean body weight? And there's a lot of controversy with that, and some decent data with just using this lean body weight. So I think of it this way. Your patient's less than 6'4", they can get close to 100. If you give a little bit more, just realizing that we're going to be increasing the duration. So we usually see anywhere from 30 to 60 minutes from that duration. But what we've been finding lately is that, shout out to my buddy, Sarah Hyland, her study showed that these people can be paralyzed up to 4 hours after. And when I mean paralyzed, I mean like not getting a neuro exam, not being able to actually, and if we reverse this, then actually changing your intervention because of that paralysis. So we have that part. Metabolism going to be endemethylation, renal excrete, very few adverse effects, very few issues compared to Succs that has a ton of contraindications that literally leads to either malignant hypothermia or increasing potassium. The time frame is where you start to get into these things where anywhere between that 48 to 72 hour range after these events is where you really have the majority of the issues with succinylcholine from a contraindication standpoint. Long story short, just if you get a VBG, or whatever point of care you can get to check potassium, then you can then we can get things at even playing ground. Because if you have a high potassium, then we're it's automatic. But then all things even, we go from there. But it's like, let's talk about the real world, like implications and logistics of all of this.
Yeah. I mean, I think like storage, right? So Succs needs to be refrigerated, right?
No, Rock
needs to be refrigerated. Yeah. And then Succs doesn't. So, of course, like we don't, most of us are not doing medicine in like a tent, but some of us are. But, for our pre-hospital providers and for people who are doing austere medicine, that might be an issue. And you might have to sort of plan around what is available to you.
Yeah.
I think a big piece, and I think we were talking about this beforehand, was really the like ease of use, the comfort level, and sort of the understanding of each drug.
Yeah.
And, there can be a million great studies that are fresh and show some really, incredible data, but it takes time. I think it takes a lot of time for people to really sort of change their ways, and that's why people get so, they emotional about it, because they're like, this is what I know. This is what I do. And I think that's really the big piece is, one, just not feeling comfortable with the drug that you don't use. So I know that we were talking like there's different shops that like are rock shops, and there's places that are really just Succs. And so I think those are the big pieces. I think when it comes to like clinical scenarios, I think with Sugammadex being, if it is available to you, which a lot of times it is, and if it's available to you in the emergency department and you have quick access to that, I think the argument around neuro patients, I think is going to really, it's going to take time, but is really going to start to fall out of favor, especially given that there is evidence to show that people especially with really bad TBIs actually have worse outcomes with Succ. So, I mean, I think in our shop, we've seen it. We've been in the room intubating together with bad brain bleeds or TBIs. And, it's sort of about the other people in the room and, other consulting services and having a conversation about, what they're comfortable, their feelings around it. I think like the idea that giving somebody rocuronium is going to preclude them from a neuro exam. I think now, especially with Sugammadex, that conversation really needs to stop.
And I know some of my pharmacy colleagues are going to look at this and say, Jimmy, I don't have Sugammadex. Then we can start going old school.
Then you go old school. Like that's
neostigmine. We have neostigmine and atropine. It's the old reversal agent. Look, that's cheap. That's dirt cheap. It should be readily available. So that part is not there, but it's like having these conversations and having them up front. Hey, these are things I have available to reverse. If you really want to use rock, use rock. If that gets you your area first, please do that. You dose it accordingly and use it. But realize if we having a conversation about how long it lasts, that's really, for me, that's my goal. We know this is going to happen. We know it's going to last a lot longer, up to 4 hours. And when your consultants come down, other components, like if we're having a conversation, we're also saying, hey, what are we giving after? Fentanyl, propofol. Those are the conversations for great shops. I've been consulted different places where they don't have drips.
So, and I think I can talk about like that later, but that's like the bigger piece is really with rocuronium is like, what are your plans and what's your checklist for afterwards? And also thinking about certain clinical scenarios. So like you always need to have a sedation plan, and that should be part of your pre-intubation checklist. And here, that is how we are taught, is that we shut everybody up and we go through our list, and that list includes sedation. And so, nursing or you have the propofol, have the fentanyl ready to go before we push intubation drugs. So I think that's one piece. I think there's certain clinical scenarios that you just have to be thoughtful of and think about, like, is this prolonged paralysis? Does that need to be reversed? And one would be these neuro patients to get an exam. I think we never want to intubate people with profound metabolic acidoses because we're not going to be able to, no matter how high a respiratory rate you can set on a vent, like if they're that profoundly acidotic, you're not going to be able to keep up with their minute ventilation. And so the thing is with having their own respiratory drive, but the thing is that those patients need to be intubation should be your last ditch effort. And those people need to be resuscitated far beyond that. But there are times and that's happened to us where it's like, well, we're kind of at this point where we have to do that. So those are the things you have to think about. But it's not about, you can't do this with this, or you can do this with that. It's having plans, is having an A plan, a B plan, and a C plan. And especially having a plan after you guys have done we've done the high five and we got the tube in. So that's the big piece. Yeah.
I always tell people, like, Succs, you have to have a plan before.
Yes.
Rock, you have to have a plan after. You have to have all your data. Hey, this patient, I check for HD lines and fistulas, things of that nature, checking for all that, checking their history. Again, we have the information. Great.
Yes.
But I think that kind of pushes people to rock, which you had to have a plan for sedation after.
Yeah.
There's data saying that having a pharmacist involved in that process decreases your time to analgesia and sedation by 20, 30 minutes.
Yes.
But again, all that being said, having that plan set helps out. Unfortunately, what I'm hearing from a lot of people, and what you probably know as well, outside of these shops that kind of do this a lot, that's not the case. People panic and just do stuff. And we've gotten patients shipped to us with 200 of rock on, no sedation, no neuro exam. And speaking of neuro exam, that can be done prior to sometimes if we have a good enough call. That helps us out quite a bit too. But I think the issue getting the data from the people beforehand for adult patients. So again, Kelsey, Emily, don't kill me. Getting those people looked at early versus rock is going to be everything after. But let's go into little snippets of data. And I guess my job today is to make a push for the Succs people and be pro Succs in this scenario. And we can kind of caveat this looking at 3 different components. We can look at efficacy and safety and things of that nature, and then looking at whether or not we have like reversal agents available to us. So I guess I'll look at this. One of the studies that's most recently done that saw a decent amount of patients was this April colleagues, and we'll throw this up in the show for you guys to see, but it found no significant difference in first pass intubation success rate between ROC and Succs, and they're dosed appropriately. And I would caveat that by saying that this is going to be in this one particular study, but this is no major difference. And to me, when done correctly, when done under scrutiny, it's going to be done fine. And then the meta-analysis came out. It's a Cochrane review. Actually said that succinylcholine was superior for achieving excellent intubated conditions. And I can see that because when we start looking at these studies and we start digging a little deeper, depending on what dose of ROC you get, we'll kind of dive into that. But there's a trend towards in the average patient that's not sick, that we need no information on. This Cochrane review looked at a bunch of different studies and said that it was better. So for me, for the shops that are doing this, we have data saying that if that's what you like to do, you can continue doing this.
Yeah.
But we currently don't work at one of those type of shops.
Yeah.
We work at a ROC shop, I like to call it. So let's talk about the data for efficacy for this as well.
Yeah. I mean, I think, that study there, especially with the April study, like there was a difference, especially with ROC doses above 1.2 mg per kg. So, whether, if there wasn't a difference, maybe, it's hard to compare with lower doses. I think, there was a study in 93 that the onset, so I think there's an argument a lot that like, well, Succs is faster on. And I think that's like, there's a study in 93 that showed that like the onset of ROC at a dose of 1.2 mg per kg was like pretty similar to succinylcholine. And I think like I was talking about this before, but like I feel like when I've used ROC versus used Succs, I feel like I get that sort of like immediate visual feedback. And instead of like with succinylcholine, then I'm like, oh yeah, okay, that felt really fast comparatively when I'm like, okay, and we put the ROC in and now I'm looking at the clock and it feels like more of an eternity, but I don't know if it seems like that might not actually be true. Yeah. So I think, I think the safety profile, especially for ROC is, and whether that's just because it's a younger drug and we had like things haven't really come out of the woodworks yet. But I think like we just know succinylcholine, especially for patients that are in the emergency department where like we don't like, especially if they're that sick and we're having like, we might not have a history on them. Like we just know that there's really profound, there can be really profound side effects with Succs that I just think that a lot of the argument for if they're both similar, I think, I don't know why ROC we shouldn't be doing it wrong. Yeah.
And a couple studies I'll just highlight as well is looking at the Watts study. We talked this before about having an ED pharmacist involved. Watts in 2012, like a cohort study, like 200 people looking at ROC and Succs. And they said that the mean time to post-intubation sedation was significantly greater with Rocuronium compared to Succs, about 30 minutes compared to 15. So almost double. But again, we kind of argue back and forth. Having a good plan kind of helps mediate that. But when your patient's not sedated. Oh, I know. With Succ. And I had a patient today. They got Succs and we got our neuro exam and they were fighting us and kicking us. And it's like, okay, maybe I should have just like been more heavy handed with my sedation. Yeah. But some people will, that's the argument that I have that sometimes ROC doesn't allow you to see that. And if you don't have a plan or if you're super busy, then you don't necessarily get to do that as much. But that's my kind of caveat when it comes to like efficacy of this, and then realizing that we probably have similar, or depending on what study you're looking at, slightly better, and what dose you're talking about, slightly better, what Succs for my argument. But again, as you mentioned, in yours is that depending on what dose you use, it may be the complete opposite. Yeah. So and then there was like also from a safety perspective, there's a study in 2016 that which I think is really a nail in a coffin with some of our neuro patients, but that ROC was associated with lower mortality in high to severe TBI patients like that, that's really hard to unsee, especially with these patients. So,
Yeah. Yeah.
And with the Succs though, again, we keep mentioning like the distorted paralysis, and we know what we're dealing with when it comes to Succ. And I think if you mention that, we have an extensive amount of literature and history. So if you know what you're doing and you view these things from a Succ standpoint, you have that. But again, I can't argue with mortality benefit. And shout out to Sid Walla for actually one of the ED pharmacists, one of the OGs in ED, for conducting this study back in 2016. He's moved to Australia now. So
oh, wow.
He's having a good time.
Yeah.
All right. Let's move on to the next part. We've kind of chatted about this a good bit, reversal agents and post-intubation management. The good thing about Succs is that you don't really need a reversal agent because it basically reverses itself. Those blood succinylcholine is going to be biting up this stuff immediately, and you have this faster time to recovery, which can be beneficial. But I know you have a kind of a rebuttal to that.
Yeah. I mean, I think there are things that are really helpful, like that you can get that is helpful for your patient to get if they're still paralyzed. That being said, that they have adequate sedation is that, especially it's a good idea to, you intubate somebody and then go look at the ventilator and really get a better understanding of the physiology of your patient's lungs, and that a lot of those maneuvers and tests are best done when a patient is paralyzed. Yeah. So I think there's a lot of data, or there's a lot of data that you can get just understanding your patient's physiology from that perspective. I think that especially those patients who are just rocking, like who you've kind of had to put down for agitation purposes, like that is a terrible place to be in, is that you get called from a nurse and you said they self-extubated themselves. So I mean, I think there's that all in the caveat is that you have to, again, like it is not okay, ever okay to paralyze and not sedate a patient like that. And I think like the idea of like, well, their blood pressure's soft, they're septic, you can put pressors on. These patients need to be adequately sedated, period, end of story. So I think in that context, if you have a good plan, there are benefits for the management of your patients sometimes to keep them paralyzed for a little bit longer. And if you don't need them to be, like, we have Succ, and Succ is not that expensive, and it's becoming more readily available. So if you don't have that, again, you can do what is it, glycopyrrolate and neostigmine. But I think really, I think the age of most places are moving towards ROC and towards Succ. So I think like that answer of like not wanting them to be paralyzed is starting to become more and more. Yeah,
it's something we can do about it. It's something we can do about it. And I think, again, we keep harping on it. And I think the whole theme of this, if you have a plan,
you gotta have a plan. You have to have a plan
for either one. I had a case back before, one of my buddies, and I said, patient's potassium can be like 5.2. Actually, this is at a Succs place. They was like, nope, Jimmy, I want to use Succs. I was like, potassium go up by 0.5 or more. And she was like, well, we'll fix that when it happens. And I was like, okay, trust, like, a patient doesn't have HD or anything like that. Again, it can be like, it could be hemolysis, all these different things. So we put Succs, and patient gets a little Brady, gets a little pointy T waves, the QRS widens out. Potassium like 6.2 now. Yeah. So I'm like, oh, of course I had calcium ready. I had to have a plan. And we got it situated, gave some insulin, things of that nature. But it's like looking at both sides of this, it's like, crap, okay, I have to have a plan for all of this, whether I'm using ROC to reverse or, again, managing the complications of Succs. Yeah. If you're prepared for both, then I think that helps out quite a bit. That's kind of the data and some of the big caveats, the efficacy, the adverse effects, and just whether or not we're going to be reversing or post-intubation sedation. But let's kind of talk about your experiences with both. You've used both. Yeah. What's kind of your thought, and where do you prefer one versus the other?
I mean, I think like I have used, and I think we are becoming a ROC shop. Yeah. But I think the idea of using Succ is becoming more and more popular to us. But also, again, it's that piece of, having the entire team on board and involving consultants. And I think like we're still in the place where, patients who are getting intubated for certain traumas and neuro patients, a lot of times they're still getting intubated with succinylcholine. So that's my biggest experience I haven't had any adverse reactions that I know about. And there is a part of me that like does enjoy having that visual, feedback, but I think that's not, logical. And I think that's not really panned out in the data. But for the most part, I would say I've used Rocuronium. And that's just mostly what I've used for most of my patients. So I think I sort of have played with like dosing, and I have noticed that I feel like the dosing does matter about onset, and then especially how long they're still going.
And that's one thing I always say is like, especially when it's July now and interns come on, I say, hey, what do you want to use? They say rock, and it's like the only thing I won't let you do is underdose your paralytic.
Yes,
because that's where we get into issues with first pass success. And like, after you practice for a while, you notice that okay, a lot of things don't matter as much. For me, the dosing and how you do certain things, that does matter. So I'm not going to let you give like 40 of rock.
No,
I'm not going to let that happen. And again, I don't want to give everyone doesn't need 150. Like Mimon, that's 50 kilos.
Mimon does not need that.
150. But it's like at the same time, you got to work through a lot of these things. So I think that's space. And then from my perspective, I'm like, I've used both. I've been at different shops that had 80% rock versus 80% Succs. And I've gotten to the point now where whatever gets the tube in quickest, I can fix everything else. Again, I always want to look at drug interactions and contraindications, kind of real contraindications from the time standpoint, and learn how to fix it. That's my biggest thing. And rock it's intriguing because some people store it, but there is some data out there on a 60-day dating of this outside of the fridge. So this came up with some virtual RSI kit when we go to physical. They was saying like, well, it has to be fridge. I'm like, well, depending on where you work and depending on what your pharmacy allow you to do, that's kind of a caveat. But that's all of my kind of big pieces when it comes to this. I want to kind of wrap up and just go from there. I think we got pretty much everything set. So I would say just emphasize that the main arguments for Succs is that it says it works a little better depending on what dosing you use. Quick on, quick off, no need for reversal agents, but you got to be very timely and understanding of the adverse effects. What about rock?
Just rock is rock. Yeah. Rock is good. It's gonna hit just pretty much just as fast as succinylcholine. It's just gonna last longer, and you got to be prepared, which I think you got to be prepared for an airway in all parts of the airway, and you have to have an A, B, and C plan for all aspects of it, because all of our airways are difficult airways until proven otherwise. So I think if you're coming from an EM perspective or critical care perspective, like that is your thought process. And I think rock forces you to have those thoughts and those backup plans. So yeah, I'm a pro rock.
I guess the choice really depends on a few things. For me, it depends on what your shop is used to, what gets the tube in the quickest and the best. But also it lets me know if I have a neuro exam beforehand, I'm not as worried about it after. It just really depends on like, do I believe that data with TBI and Succs causing increased mortality? That's something I want to consider. And then this again for adults only. So it really just depends on, I want a quick off. So whether that's going to be reversal or using a different agent really depends on my team. So that's something that works with me. And I realize this episode's going to probably get us a lot of flack because people are very, very, very set in their ways. And if it gets your patients intubated and the neuro exam happens appropriately, continue doing what you're doing. What that may look like. So that's really my big thoughts of it. Anything else for audience?
No, I think this was a very cordial, professional conversation. There was no punches thrown, so yeah.
Perfect. Well, we're going to go ahead and wrap up, and I wrap up the same way every single time, guys. You don't have to be a pharmacist. You don't have to work in ED, but everything you do, make sure you farm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.